Hi, everyone. Thank you for joining us today. I'm Brendan Doherty, Director of Communications for the Scleroderma Research Foundation. We're pleased to have you with us for our 21st live webinar. As research, diagnostics, and treatment options continue to evolve, it is our commitment to bring these latest developments to you. For all of us at the SRF, it's an honor to be able to provide this forum to the scleroderma community. Our SRF webinar series is made possible by a generous grant from Gilead Sciences. We would like to thank them for their continued support. It's now my pleasure to introduce our special guest. Dr. Elizabeth Volkmann is a rheumatologist and is founder and co-director of the UCLA Connective Tissue Research Program in Interstitial Lung Disease, or ILD, and contributes to the Connective Tissue Disease Research Area at the UCLA Microbiome Center. She's an active clinical and translational researcher with a special focus on systemic sclerosis, with an emphasis in investigating the pulmonary, gastrointestinal, and vascular dimensions of this disease. Today's session will feature 40 minutes on recent research and developments and treatments for ILD. We'll wrap up with about 15 minutes for question and answer time. The phone lines have been muted, so if you have a question, please use the chat box in the conference window. Remember that our webinars are for educational purposes only, and no information provided is considered personalized medical advice. It's now my pleasure to turn the presentation over to Elizabeth and treating scleroderma interstitial lung disease, an update on recent research and treatment options.
All right. Thank you, Brendan. Thank you for the kind introduction. I see that some people are having a difficult time hearing, so hopefully I'm speaking loud enough. But I'd like to thank the Scleroderma Research Foundation for inviting me to participate in this webinar. And I'd also like to express my gratitude to all of the participants who are taking the time to learn about new treatment options for scleroderma lung disease. So to begin, I'm just going to give an overview of systemic sclerosis-related interstitial lung disease. This will be abbreviated throughout the talk as SSC-ILD. And I'll begin by discussing current treatment options for this condition and reviewing some of the pivotal clinical trials that substantiate the use of the medications we currently use for treating SSC-ILD. I'm also going to discuss some of the long-term outcomes of patients who have been enrolled in some of these trials, because we feel this is important, not just looking at what happens at the end of a 1 or 2 year trial, but how these medications can affect patients in the long term, 5 or 10 years after their diagnosis. I'll then discuss the results of the scleroderma lung study 2. This study was recently published last month in the Lancet Respiratory Medicine, and I think the results of this study will not only help inform how we treat patients, but also how we design future clinical studies. And then I'll end by discussing some of the new agents for SSC-ILD. And this is an interactive webinar, so I would encourage you to think about questions along the way, and there'll be ample time at the end for asking the questions. So to begin, as most of you are well aware, systemic sclerosis affects multiple organ systems. But interstitial lung disease, or ILD, occurs in the majority of patients with scleroderma. So when studies have looked at consecutive patients, for example, followed in a clinic, if all of those patients get a CT scan just to screen for interstitial lung disease, about 55 to 65% of patients have some evidence of interstitial lung disease on their CT scan. If you look at patients who have abnormal pulmonary function tests, the prevalence of finding interstitial lung disease on the CT scan goes up. So this is a problem that again affects the majority of patients. And it is also now the leading cause of death in scleroderma. So it's a very serious problem. What are the symptoms? Well, early on, patients can complain of fatigue, which is relatively nonspecific. But over time, patients can develop shortness of breath on exertion. This usually begins with feeling short of breath while walking upstairs or walking up a hill. But it can worsen to the point where it can become difficult to do regular activities of daily living, like bathing or cooking or even brushing your hair without getting short of breath. Eventually, in extreme cases, this can progress to shortness of breath just at rest sitting quietly. And cough is a common complaint, and this is the second most common symptom after shortness of breath that occurs in patients with scleroderma lung disease. So what does this look like? Some of you may have reviewed your CT scans with your physicians. So this is looking at the top panel sort of directly at the lung, and at the bottom panel as if the lung is sliced in half. And on the left is a patient who actually participated in our first scleroderma lung study at UCLA, and this patient has mild interstitial lung disease. So normally the airways of the lungs should be nice and dark, and that basically represents air. You can see, for example, in panel A, there's some grayness at the bottom, and this represents reticulations or fibrosis. This patient really just has a mild amount of this gray area. But you can see in panels C and D, this is a patient with more severe interstitial lung disease. So there's not as much of that healthy black space that just represents normal airspace. And there's more of the reticulations and even more of what we call honeycombing, which represents more end-stage fibrosis. So how do we treat scleroderma lung disease currently? Well, the two most common drugs that are used right now include cyclophosphamide and mycophenolate, and these are abbreviated as CYC and MMF during this talk. I'll begin with discussing cyclophosphamide because this was the agent that was first studied for scleroderma lung disease. And the evidence came from a large randomized controlled trial that was done at 13 centers throughout the United States, comparing patients who received cyclophosphamide versus placebo, and placebo is basically getting nothing. So these were all adult patients with scleroderma ILD. There were 158 enrolled in this study. All of them had relatively early scleroderma, so in order to be eligible for this study, they had to have scleroderma diagnosed basically within 7 years of being enrolled in this study. As I mentioned, there were 13 centers, and this compared oral cyclophosphamide versus placebo. Now, some people give intravenous cyclophosphamide for treating scleroderma lung disease, but this study looked at oral cyclophosphamide given daily. And the reason they used oral cyclophosphamide was just for feasibility. It was much less expensive to do that. And it was a 1-year study. And notably, this study excluded patients who had pulmonary hypertension. So this was really just looking at patients with parenchymal lung disease, interstitial lung disease. And the primary outcome for this study was something called the forced vital capacity. This is a parameter that's measured when you get your pulmonary function test or your breathing test. And this is a measure of how much restriction there is in terms of the airflow in the lungs. So on the left side represents the patients that were randomized to the cyclophosphamide arm. And if there's an improvement in the FVC goes up. So you can see about 49.3, or roughly half of the patients, had an improvement in their FVC during the study, whereas the other half actually had worsening. In the placebo arm, which is on the right in the dark bars, only about a quarter of patients experienced improvement, but the overwhelming majority had worsening. So this told us that there was some benefit of using cyclophosphamide compared to doing nothing for these patients. However, you can see in terms of the patients who improved in the cyclophosphamide arm, most of them improved by a very small amount, between 0 and 5% of their FVC percent predicted. So we wondered whether this was really a clinically meaningful improvement in the FVC. However, this study also found that there were improvements in a number of other secondary endpoints. So we asked people about their shortness of breath using valid questionnaires, and this improved during the study. Their quality of life also improved during the study using these questionnaires. And we also measured the extent of fibrosis on their CT scan, and this as well improved. And we measured the fibrosis. We both had a radiologist read the CT scans and note improvement from the baseline visit, the first visit, to the end of the 1 year. And we also used something called quantitative imaging analysis. This is when a computer actually computes the percentage of, CT pixels that represent fibrosis. So it's a much more objective measure of improvement. And this also demonstrated a significant improvement. And then finally, there was an improvement in the total lung capacity, the TLC, which is another measure on your pulmonary function test. But there were significant safety concerns with giving cyclophosphamide, and many of you may have received this medication in the past. You can see from this slide, this is looking at year 1 of the study, and then they also followed patients for a second year off of medication. And during that first year in the cyclophosphamide arm, what's highlighted with the orange box is that significantly more patients experienced leukopenia and neutropenia. And basically, this represents low white blood cells. And what does this mean for the patient? Well, when the white blood cells are low, you're more at risk for getting infections. And you can see this by the increase in number of pneumonias in the cyclophosphamide group compared with the placebo group. Importantly, as highlighted in the light blue box, there was no difference in death comparing the cyclophosphamide group to the placebo group. But as I mentioned, these patients were followed for an entire year after the study ended, just to see if the effect of cyclophosphamide continued. And what this graph demonstrates is that by the end of the 2-year period, there was actually no difference in the FVC percent predicted between the two groups. So the line that has the open circles, those are the patients in the cyclophosphamide group, and the line that has the closed circles, these are the patients in the placebo group. And you can see that the cyclophosphamide group is winning, right? And it peaks at about 18 months. But by the end of 2 years, there's no difference between the two groups in terms of the FVC percent predicted. Similarly, when we looked at the total lung capacity, the TLC, the same findings were reported. So there was a significant difference, 12 months and up to 18 months. But then by 2 years, there was no difference between these two groups. So this told us that, cyclophosphamide likely has an effect on lung disease early on, but maybe needs to be given longer, or another medication needs to be given longer to prevent the lungs from worsening after that first year. We've also now started to explore long-term outcomes, so even longer than 2 years in these patients. So this is a follow-up of the patients who were enrolled in this study, and those patients were enrolled between the years 2000 and 2004. And then we actually followed them up through 2012. So some of them had almost 12 years of follow-up. And we looked at survival as the primary outcome, but we also looked at what patients developed organ failure in a number of different organ systems, and what patients developed cancers. So during this follow-up period, actually 42% of the cohort had unfortunately died. And only 25% were alive without any evidence of organ failure. 11% were alive with organ failure, and about 20% we could not reach, so we used their last known date to be alive. And this is a chart looking at survival. So the blue line represents those patients who were in the cyclophosphamide group, and the red line are those patients in the placebo group. And what this slide demonstrates is that there was no difference in long-term survival between these two groups. The lines are very much intertwined. So this told us that treating patients with 1 year of cyclophosphamide led to early improvements in the forced vital capacity and breathing, but really didn't have much effect on overall survival long term. We also looked at organ failure, and the overwhelming majority of patients who developed organ failure, not surprisingly, developed organ failure of the lungs. And we define this as the need for using supplemental oxygen or the need for lung transplantation. But there was no difference in the rate of developing organ failure between the two groups. And in addition, in terms of cancer, there was absolutely no difference between the two groups in terms of the rate at which people developed cancers. And the cancer rates were fairly low in both groups. So clearly after these studies, we knew that we had to do better. We had to give a medication that we could give for a longer period of time, because cyclophosphamide you don't want to give for too long because of the safety concerns. And so investigators started to look into treating patients with something called mycophenolate or CellCept. And this is a medicine that's used in a number of other autoimmune conditions, including lupus. So the scleroderma lung study too was designed. This was also a multi-center study. It was done at 14 sites in the United States. Many of the sites were the same as the sites that participated in the first scleroderma lung study. It was double-blind, meaning that neither the patients nor the investigators knew which drug they were getting. And patients either were randomized to getting mycophenolate, and they got this twice a day for 2 years, or cyclophosphamide. And this was given just once a day for 1 year, and then in the second year they received placebo. This is just a graph further explaining how patients were randomized. So again, there were 142 patients. The eligibility criteria were very similar. So these are patients, adult patients with scleroderma lung disease who have relatively early disease and are symptomatic and who don't have pulmonary hypertension. About half of them got the mycophenolate for 2 years, and the other half got cyclophosphamide for 1 year, followed by 1 year of placebo. And again, this was oral cyclophosphamide. These are the sites who participated in this study, and UCLA, where I practice, was both the clinical and data coordinating center for this study. There were a number of important assessments that occurred, and these are assessments that your doctors probably perform in the clinic or should be performing on a regular basis to measure how your scleroderma lung disease is progressing. So PFT stands for pulmonary function tests, and these were done to screen patients, and they were also done at the time of enrollment and then every 3 months afterwards during the 2-year period. Skin score was also done because we wanted to see if mycophenolate had an effect on the skin. And then HRQOL stands for health-related quality of life. So these are those questionnaires that I mentioned that assess how much shortness of breath someone has and how this disease is impacting their quality of life. And then finally, the HRCT, that's the chest CT. This was done at the beginning of the study and then at the end. And we thought that the FVC percent predicted over the course of 2 years would be better in the patients who got mycophenolate compared to those who got cyclophosphamide. But then another important aspect was we felt that the mycophenolate would be safer. And this we felt was an important consideration when you use really significant immunosuppression. So the primary endpoint for this study was also the forced vital capacity, or FVC. And you can see from this slide that there was no difference in the course of the FVC between the mycophenolate group and the cyclophosphamide group. So the dotted line are those patients in mycophenolate, and the solid lines are those patients who received cyclophosphamide. And you can see that the lines basically are parallel to each other, and there was no significant difference in the course of this outcome between the two groups. So they were similarly as affected over the course of 2 years. If you remember, I showed a similar slide like this when we were looking at the scleroderma lung study 1, but this is showing the change in the FVC from baseline to 24 months or 2 years. And you can see in the cyclophosphamide arm, about 65% of patients had an improvement, and about 71.7% of patients in the mycophenolate arm had improvement, whereas 36% in the cyclophosphamide arm had worsening, and 29% had worsening in mycophenolate. Again, these are roughly very similar between the two groups, and there was no significant difference in terms of the change in the FVC. But tolerability was, again, as I mentioned, an important consideration in this study. And this slide shows the time to withdrawing from the medication. So when the patient in the study decides they cannot take the medication anymore, or the doctor tells them they cannot take it anymore due to an adverse effect or a side effect that's intolerable. So the dotted line are those patients in mycophenolate, and the solid lines are those patients in the cyclophosphamide arm. And you can see that more patients who received cyclophosphamide withdrew early compared to the mycophenolate arm. And most of these withdrawals were due to side effects of the medication. This is looking at safety, so the number of adverse events, AEs, and the number of patients who experienced these adverse events. And you can see that leukopenia, which again is the lower white blood cell count, making someone more likely to get infection, occurred more often in the cyclophosphamide group compared with the mycophenolate group. Also, thrombocytopenia, this is low platelet count. This occurred slightly more often in cyclophosphamide compared to mycophenolate. But there was no difference in the rates of pneumonia between these two groups. In terms of serious adverse events, these were roughly similar between the two groups, but I will point out that more adverse events related to treatment occurred in the cyclophosphamide arm compared with the mycophenolate, and over twice as many deaths occurred in the cyclophosphamide arm compared with the mycophenolate arm. So overall, this told us that these two drugs have a similar effect on lung disease over the course of 2 years. However, there are some safety concerns about using cyclophosphamide. Mycophenolate appears to be better tolerated and is associated with fewer deaths. So we've begun to follow these patients enrolled in this study long term. And as of now, patients have about an average follow-up of 3 years. We're still following these patients. There have been more deaths that have unfortunately occurred, 22% in the cyclophosphamide arm and 17% in the mycophenolate arm. And one patient who received mycophenolate has gone on to get a lung transplant. This is a slide again showing the long-term survival in these patients. So the dotted lines are those patients in the mycophenolate arm, and the solid line are those patients in the cyclophosphamide arm. And you can see up until about 3 years, there is a survival advantage for getting mycophenolate. And then beyond 3 years, it diminishes. And part of this reason maybe we need to follow people longer. So this survival effect may continue as we follow people longer who enrolled in this study. We also looked at what baseline factors when a patient enrolled in the study could predict their survival. A number of what we call observational cohort studies, or studies following patients that are followed at a single, medical center, they've identified certain factors that predict survival. But no one has looked at this idea in the context of a clinical trial where all patients are treated the same. They all are treated relatively aggressively for their lung disease, and we can control for which medication they received. This cannot be done in the setting of an observational study where patients can be receiving different agents. Some patients may have good access to their health care. Some patients may have barriers to their health care. So in doing this, we wanted to identify what factors were associated with worse survival or death in these patients. And the first factor that was important was age. So the older the patient was when they entered the study, they had an increased risk of death. Also, their baseline forced vital capacity. So how much restriction they had in their lung disease or their severity of their lung disease. If it was worse at baseline, they also had worse outcomes. But the single variable that actually had the most impact on survival was their disease duration, which is highlighted in this red box. And you can see that those patients who had a disease duration of less than 3 years had much poorer outcomes. And we think this is because patients who present in a very aggressive way with their scleroderma, usually these are patients with diffuse skin disease, often have worse outcomes because their disease progresses so rapidly. But this was quite a striking finding of this study. So I'm going to transition now from speaking about some of the evidence to support what medications we use now for treating scleroderma lung disease with some of the newer medications that are available. And some of you may already be familiar with some of these therapies. So here's a list of a couple of the ones I'll speak about. So RITUXANAB, TOCILIZUMAB, and I'm also going to speak about stem cell transplant. So we'll talk about rituximab first. So this is what we call a biologic medicine. It's an infusion medicine that's usually given every 6 months, and it targets a certain aspect of the immune system, the B cells. It's a medicine that's used to treat conditions like rheumatoid arthritis. But there's recently been some evidence that depleting the B cells or lowering the B cells may be important in treating scleroderma lung disease. So far, there's just been some open-label trials, case reports, and one small randomized controlled trial supporting the use of this drug in treating scleroderma lung disease. And those reports, even though they were small, did suggest an effect of RITUXAN. Currently, there's a large trial that's underway in the UK comparing intravenous cyclophosphamide with rituximab, and the results of that study will be very important in revealing in terms of does this medication actually work. At our center, we typically use rituximab in cases where patients don't respond to mycophenolate, which is now our first-line treatment in most cases, or they cannot tolerate cyclophosphamide. The next relatively investigational drug is the tocilizumab. So this is another biologic medication that's given through an infusion, and it targets another aspect of the immune system, interleukin-6 or IL-6. And this medicine is used already, and it's been used in rheumatoid arthritis, adult onset Still's disease, and a number of other autoimmune conditions. There has been evidence that IL-6 levels are higher in patients with scleroderma, especially patients who have diffuse skin disease. And a study was recently published. It was a phase 2 trial comparing tocilizumab with placebo. And this study was designed just to look at skin score. So it was mainly a trial about how this drug works in terms of treating skin disease in scleroderma. But they did notice that over the course of 48 weeks, so almost a year, fewer patients who received tocilizumab had a decline in their FVC or worsening in their restrictive lung disease. Now, one caveat is that not all of the patients in this study had lung disease, so it's difficult to determine whether this truly has an effect on lung disease, but it's somewhat promising. And a phase 3 clinical study is currently underway. And then stem cell transplant. I'll spend a few minutes speaking of this because this is a question I often get in clinic because there's a lot of reports in the lay media about stem cell transplant for a number of autoimmune conditions. So how does this process work? Well, the first step in stem cell transplant is harvesting white blood cells from the body. And there's essentially 2 main ways to do a stem cell transplant. One way is to get the cells from your own body, which is called autologous transplant. And another way is to get the cells from someone else, a donor, and that's called allogenic transplant. In scleroderma, we tend to use autologous transplant because we feel there's a lower risk of rejection and getting something called graft versus host disease when you use cells from the your own body. And graft versus host disease is actually very similar to scleroderma in terms of how it presents. So the first step is giving a medication called G-CSF that basically stimulates the bone marrow to produce a lot of white blood cells. These white blood cells are taken out of your body using a process called leukapheresis, and then they're run through a machine that selects for the specific cells that we think are most important in rebuilding a healthy immune system. And these cells have a marker on them that are CD34 positive. After those cells are harvested, patients undergo a conditioning regimen where they receive high doses of cyclophosphamide, so much higher than what is normally given for treating scleroderma. And then some centers also use radiation as well. So once the immune system is essentially wiped out, then these cells are reintroduced into the body. So it's somewhat of a lengthy process, and there is some risk because the immune system is significantly depleted, so patients are at a high risk for infection during this time and other complications. There has been one very large study that was done in Europe, and it's called the ASTIS study. And this study compared patients who got stem cell transplant with patients who received cyclophosphamide for scleroderma. And they did find that patients who got the stem cell transplant had an increase in their FVC compared with patients who just received cyclophosphamide. But there was a high mortality rate in the first year, so 10%. So 1 in 10 patients who got the stem cell transplant died in the first year of the study. In the long term, they did better in terms of survival, but that first year, the mortality rate was high. So this is a very risky procedure, and we generally only consider it for carefully selected patients who we think won't have that complication in the first year. A study in the U.S. Just finished, just recently a couple of months ago, and this study was also done at multiple centers looking at stem cell transplant. So very soon we should have the results of that study to determine whether stem cell transplant worked in the U.S. population. And then we're very fortunate that the pharmaceutical industry has taken an interest in developing even newer drugs for scleroderma. So previously, drugs like cyclophosphamide and mycophenolate have essentially been repurposed from studying other diseases, from studying scleroderma. But these are drugs that really are designed to treat lung disease. And the first one is nintedanib. This is a medication that's already FDA approved for treating something called idiopathic pulmonary fibrosis. So similar to the lung disease in scleroderma, but we call it idiopathic because it's not associated with scleroderma or any other connective tissue disease. And there's a phase 3 clinical trial that's currently enrolling patients all over the world, and we're doing this study at UCLA. The next investigational drug is something called ACKNOWLEDGEMENTS. A phase 2 clinical trial has actually just recently started. This is another infusion medicine that's given monthly and shows very promising results. Now, both of these medications, the nintedanib and the abatuximab, for these studies, they are placebo-controlled trials, so you have a 50-50 chance of getting the drug or not. But an important thing to note when you're speaking with your doctor about these studies is that it's okay to be on background medication when you're getting these, meaning if you're on CellCept or mycophenolate now, you can continue on those drugs and still participate in this study. That way you have no chance of getting nothing for treatment, which really isn't acceptable in the current era where we have options available. And then lastly, pirfenidone. This is another medication that's approved for treating the idiopathic pulmonary fibrosis, and we're going to be starting a phase 3 clinical trial. This will be called Scleroderma Lung Study 3. It'll also be coordinated out of UCLA, but done at a number of centers throughout the U.S. And this will compare patients who receive mycophenolate with patients who receive mycophenolate plus pirfenidone. And finally, lung transplantation. So this remains sort of a last resort option for patients who either haven't responded or maybe responded initially to treatment and then developed a worsening of their lung disease. This is not performed at all transplant centers throughout the country, just select transplant centers. UCLA is a transplant center for scleroderma. And what we've found and what other people have found who transplant patients with scleroderma for their lungs is that the outcomes are similar to those patients who have lung diseases due to other causes, such as the idiopathic pulmonary fibrosis. And this is important because a lot of people in the past were afraid to offer lung transplant to patients with scleroderma because they thought that perhaps the scleroderma would get worse after the transplant and lead to earlier rejection of the lung. And we actually haven't found that occurring. The rates have been similar between patients with scleroderma and patients with other diseases. So this is definitely a viable option if you're close to or followed at a transplant center that transplants patients with scleroderma. This procedure also has significant risks, and you basically, when you get a transplant, you're committed to a lifetime of immunosuppression to prevent rejection of the lung. So it's also a serious treatment option. So I'm just going to summarize some of the things we spoke about today, and again, there'll be time for questions as well. But on the left side are the current therapies that we use for treating scleroderma lung disease, so the cyclophosphamide, mycophenolate, and lung transplant. Our practice at UCLA is to use mycophenolate most of the time as the first-line agent, and then consider cyclophosphamide in select cases, and then use lung transplant as a last resort option. But there are a number of experimental therapies with exciting results. So the RITUXANAB, again, it's an infusion medicine that targets the B cells. There's a study going on in the UK about this drug. TOCILIZUMAB, this targets IL-6, and there's a phase 3 study that's going on now for that. Stem cell transplant, we're going to get hopefully soon the results of the SCOT trial, the US trial studying stem cell transplant for scleroderma. And then the three below that are involved in new clinical trials that may be available to you where you receive care. So the nintedanib, abotuzumab, and pirfenidone. I would just like to acknowledge, a few people that I work with, and also thank again the Scleroderma Research Foundation for inviting me. My research mentor is Dr. Donald Tashkin, who has been the principal investigator for all of the scleroderma lung studies, and Dr. Philip Clements, who's my clinical mentor and has actually been training me since I was a medical student at UCLA. These other individuals are involved in our connective tissue disease, lung disease program at UCLA, which is a multidisciplinary clinic for treating patients with lung disease in the setting of an autoimmune disease, and offers a lot of comprehensive care. I also work with Dr. Silver and Dr. Mays and Dr. Asasi on lung disease research in scleroderma, and also Dr. Hoffman-Vold, who's in Norway. We research the microbiome, the GI microbiome in scleroderma. So I just acknowledge these people because I think it's important in a disease like scleroderma to be working together to come up with new research and new cures. So I thank you for your time, and I'm really happy to entertain any questions right now.
We have about, thank you, Dr. Volkmann. We have about 15 or so minutes left, and we'll use that time to answer some of the questions that come in. Just a reminder, if you have a question, go ahead and type it into the chat box to the left of the main slide window. We'll try to get to as many as we can. We have several coming in. One of the first ones was about the median age, Dr. Volkmann, of the SLS2 trials. Did you happen to know the median age there?
Yeah, so in general, in SLS1 compared to SLS2, there was a slight difference in age. So the patients in SLS2 were slightly older, but the average age for both groups was around 55. And this represents sort of the average age of scleroderma in general. So it represents sort of a normal scleroderma population.
And then a follow-up on that particular study, the SLS2, somebody noted that you have to be pretty healthy to get a lung transplant. Usually GI issues are something that precludes somebody from being included in something like that. Any comment?
Yeah, no, that's a really good question. And the GI symptoms in particular have been what have scared some transplant centers from offering transplant to patients, particularly patients who have bad esophageal reflux, because there's this worry that if people have reflux that's not controlled, they can aspirate, and so some of those stomach contents can go into the lung and promote inflammation. But at least at UCLA and also at UCSF in our studies, we've included patients who have significant reflux disease, and they've had similar outcomes as patients without reflux disease. So it's an important consideration and definitely a dimension of the disease that has to be addressed, but we don't think it should preclude someone or make them ineligible for transplant.
We have another question. When will we hear about study outcomes on the last 3 drugs that are used for IPF?
So that's a really great question. You know, these studies are just starting, and the duration of the study ranges from 1 year to about 2 years. And then after a study is done, there's a period of time where all the data has to be analyzed. So I think the results of that study probably won't be available for another 3 years, although sometimes they release preliminary results of the studies earlier than that, and these are presented at some of the national and international meetings. And then also what can happen, which what we hope doesn't happen, is that if they find there are safety concerns, sometimes the studies are stopped earlier. But those results won't be available probably before 3 years.
One of our listeners asked, what do the results imply for someone that's had a year of cytosine infusions followed by ongoing oral CellCept? Thanks.
So a year of cyclophosphamide, is that what you said?
Mm-hmm. Mm-hmm.
Okay. So yeah, that's a very good approach. We know from the first scleroderma lung study that just giving 1 year of cyclophosphamide alone is probably not enough, and a maintenance medication is needed. And most of us use mycophenolate as maintenance, so doing the cyclophosphamide first followed by the mycophenolate is a very reasonable option. What we don't know as physicians and researchers is how long to continue the mycophenolate as maintenance, and these are questions that we hope to address through looking at the long-term follow-up of patients enrolled in the second scleroderma lung study, where we're keeping note of how many patients stayed on the mycophenolate after the study ended versus those who stopped it. And we might be able to address that by comparing patients who stayed on it with those who stopped it in terms of their long-term outcomes.
We have a follow-up question there, too. Any data on cyclophosphamide start followed by mycophenolate and then off? Or
So that's something that we'll be addressing during the long-term study, but the only study that looked at maintenance after cyclophosphamide, this study looked at patients who got azathioprine or Imuran after cyclophosphamide, and those patients who responded to cyclophosphamide then went on to Imuran actually had very good outcomes. But no one has looked at it with following it by mycophenolate yet.
Somebody also asked the question, besides meds early in idiopathic or ILD, have you found other preventative measures to avoid worsening of symptoms like exercise or something else?
So that's a great question, and this is something that I like to address with all of my patients, because I think in managing such a complicated disease, it requires more than just giving a pill or an infusion. So pulmonary rehab, which is a form of supervised exercise, has actually been found to lead to improved outcomes in patients with interstitial lung disease, both with and without scleroderma. So I think exercise is really essential and something that all patients who are able to do to some capacity should be doing on a regular basis. And this obviously has important effects on the heart and other aspects of the body. You know, other things don't have a lot of research backing, but I think nutrition is important. You know, managing stress and how you cope with the stressors in your life is really important, because the immune system seems to be sensitive to these things. But again, we are lacking in research supporting this.
A couple of people have asked if there were any noted differences in male versus female patient outcomes in the trials that you're looking at here.
So that's a really good question. In general, the historical studies have shown that men with scleroderma tend to do worse and have more aggressive disease. In our studies, we haven't found such profound differences between men and women, but in general, it can be safe to say that men often do worse than women with this condition.
Great. We've gotten a lot of good questions, and I wanted to thank you, Elizabeth. It looks like we're about out of time. This was a great session, and with so much happening on this topic, I'm grateful that we're able to provide an update for patients and caregivers. We're going to wrap it up today. Thank you, Elizabeth.
Thank you. Take care.
As I mentioned earlier, this was our 21st webinar today, and I want to thank everyone who takes part in this series. All our webinars are available on demand at scleroderma-research.org. As always, we welcome your feedback. When you close the webinar window, please help us by completing the short survey. We're always interested in hearing what you want to hear about, so please be sure to include future webinar suggestions in your survey responses. Please remember that we depend on your support to continue our investment in the most promising research. For more information, visit us online at scleroderma-research.org or call our offices at 1-800-441-CURE to support our program. One quick note, our corporate partner, Boehringer Ingelheim, is excited to announce a research study for scleroderma lung disease. If you are a patient or know an adult patient with scleroderma ILD and you would like more information on an upcoming clinical trial, please visit www.scleroderma-researchstudy.com. Once again, www.scleroderma-researchstudy.com. Thanks again for sharing some time with us today. Our next webinar will be announced soon. In the meantime, follow us in our e-newsletter on Facebook, Twitter, or Instagram to get the latest research news. Goodbye for now.